Okay, morning everyone. So my name is David Wen. I'm one of the consultant interventional neuroradiologists at the Singapore General Hospital. Today we're just gonna go through what distal and medium vessel occlusion is, a little bit of the evidence behind it, as well as our experience with DMVOs. So what exactly is distal/medium vessel occlusion? Only recently, I think this distal thrombectomy summit group actually came up with a consensus statement. Before that, the sort of definition of what is distal and what is medium is not very clear. But according to this new consensus statement, distal is anything that is, you have to traverse a long distance with your thrombectomy devices, or that is tortuous. So typically what you're looking at is anything that's beyond the M1, anything that is beyond the A1, and anything that's beyond the P1. And they define medium vessel occlusion as something that has a vessel diameter of somewhere between 0.75 to 2 millimeters, so that's pretty small. So in its essence, these are the kind of vessels that you are thinking of when you talk about distal and medium vessel occlusions. Your M3, M4s, A2, beyond your A2s, beyond your P2s, and all your smaller posterior circulation arteries like your pica, ICA, and STA. And what about the M2 or the A1 and the P1? I think it really depends. Every patient's anatomy is slightly different. For some patients, the M2 is fairly straight and is similar in size to the M1. Would you consider that a distal or medium vessel? Probably not. And also, the A1 is also a typical example. Again, depends on the patient's anatomy. Some patients have dominant A1 with a hypoplastic contralateral A1, and if you have to remove a clot quite proximal in that A1, it might not be considered a distal or medium vessel. So in terms of defining both what is a distal and medium vessel, we also have to define what are primary DMVOs and what are secondary DMVOs. Primary DMVOs are what are spontaneous, meaning to say they have the same etiology as large vessel occlusions, and you find them on your initial imaging. So your CT imaging, your CTA imaging, angiogram imaging, or your MR imaging. Okay. Secondary DMVOs are what happens typically after you have given some kind of intervention, either thrombolysis or thrombectomy, and then you find that there is either a new vessel that is occluded, usually because of distal migration of the original clot, or the clot had fragmented as you were pulling it out and it has now gone into a different territory. In terms of the epidemiology of DMVOs, it's not small. It's actually 24 to about 40% of acute ischemic stroke. So it's actually a significant number of stroke cases, acute stroke cases. And about 1/3 of DMVOs, if you don't treat them or you leave them alone, patients actually do not gain functional independence at the 90-day mark. They are MRS 3 to 6. So it's quite significant. It doesn't mean that you have an occlusion of a small distal vessel, you can leave it alone. Patients do suffer some kind of disability from it. And in about slightly less than 50% of cases, if you do thrombolysis for DMVOs, they recanalize. So actually a large proportion of them don't recanalize despite IV thrombolytics. In terms of the evidence of treating DMVOs, there's actually no level 1 randomized controlled trials supporting endovascular therapy. What we have are several retrospective studies as well as small cohort studies. Okay? And in some of these studies, when you do the meta-analysis and the systematic review, there actually is no, it's an unclear answer, right? The evidence says that endovascular therapy may not be superior to best medical in terms of a patient obtaining functional independence. And this is one of the studies that, one of the sort of systematic reviews that was done not too long ago, I think 1 or 2 years ago. And I think the important thing to note is that when they concluded functional independence of patients was achieved in 62% of patients who were treated with endovascular therapy, but as well as 55% of patients who were treated with best medical, and there was no significant statistical difference between the two groups. But on the other hand, when you sort of dissect down the patient groups a little bit better, you also find that there are studies who do patient-level pooled analysis, like this one here. And in their conclusion, it does state that in patients with isolated M2 occlusions, endovascular therapy was associated with improved clinical outcome compared to just medical therapy, especially if there's a mismatch profile. And this mismatch profile means there's a mismatch between the ischemic core and the ischemic penumbra. So the bigger the mismatch and the higher the stroke severity, as defined by the NIHSS score, the more likely you are to get a good outcome from endovascular therapy. So in my mind, not all DMVOs are equal. Okay? We can't sort of lump them into a whole group and treat them as a sort of one single entity. And there are probably specific patient groups that you should consider treating if you do come across a DMVO. Right? Some of these patient groups could include patients who have a relatively high stroke severity, so higher than a 6 on the NIHSS score scale. Patients who would not be eligible for IV thrombolysis, right? Because if you don't give IV thrombolysis, a very, very small percentage of these vessels actually recanalize. M2s, especially M2 vessels which are relatively straight, they're not too tortuous, I think those you consider, and some of actually M2s supply quite a wide territory of the brain, of the MCA territory, so they are worth considering for recanalization. And the other thing is what we found also in our own hospital is if there's a risk to profession. It's very different to have a patient who's 95, doesn't get out of the house much, and she has a M2 or A2 occlusion. And you compare that with, let's say, a young patient who's in her 30s or 40s, still active, still has a job in front of them, and they have that same occlusion, exact same site. The disability to each of those patients will be very different. It may not be that devastating in someone who's more than 90, but to someone who's still fit, active, has a full life in front of them and working, especially in jobs, for example, that require a lot of hand-eye coordination, driving, or your piano teacher, and these are professions that you will consider being more aggressive in terms of your endovascular therapy. In terms of, so if you're approaching a DMVO, what we found that there are certain sort of imaging techniques that would improve your detection of DMVOs. Because the standard sort of way of imaging patients, which we use, vast majority of us use your CT and CT angiograms, they're very good for large vessel occlusions. But to sort of detect the small distal and medium vessels, they may not be as good, right? And our automated software like Rapid AI, Brainomics, they are not as good for distal and medium vessel occlusions. They're fantastic for large vessel occlusions, but when it comes to the smaller vessels, they tend to struggle, right? They're not so accurate. And the reason being that as we go further into the brain vasculature, the anatomical variation and the tortuosity of the vessel actually makes it hard for the AI software to sort of accurately pick up some of these occlusions. So in our center, what we have done is we like multiphasic CTA. So we don't only perform a single phase CTA, we actually perform 3 phases, first, second, and third, into sort of the arterial phase, so early arterial phase, mid arterial phase, and a late arterial phase. And that really helps to detect small vascular occlusions. And the way you do it is actually, if you look at this, on the very most left-hand side is your phase 1, phase 2, and then phase 3. What you will see is that progressively, in the vessel that is occluded distally, you will see delayed filling, first of all, but also what you will see mostly on the third phase, or the late arterial phase, is that the vessel tends to have contrast stagnating within just distal to the vessel that's occluded. And that's a very telltale sign that what you're dealing with is actually a much more distal vessel occlusion. And this is an example of a sort of left mid-M2 that has been occluded. On the third phase, which the slice on the most right, you can see that there's actually contrast stagnation in the sort of distal M3 and M4 vessels. Again, another example, this time a right A3 occlusion, going through all 3 phases, you can see that on the third phase, on the right side, you can see delayed washout of contrast or contrast stagnation within the A3, A4 vasculature. And that again is a very good pickup sign for distal and medium vessel occlusions. Other than CT, multiphasic CTs, we can also do CT perfusions, which again has been shown to be quite accurate for distal and medium vessel occlusions. These are some of the patterns that you could see in the anterior MCA vessels, M2, M3, A2, A3. These are kind of patterns that you would see on delayed perfusion, okay, if your vessel is occluded. For us, we have sort of slightly moved, actually moved away from CT perfusion. We don't do a lot of it. Basically because we have been so comfortable with CT angiograms, and it's actually much faster and more reliable to interpret compared to CT perfusion. But of course, if your center is very adept at CT perfusion and you do a lot of it, it is also a very good tool for picking up distal and medial vessel occlusions. So in our own experience, we have roughly about 25% of our thrombectomy cases are what we consider distal and medium vessel occlusions. And this is actually a mix of both primary and secondary. I would say most of our cases are secondary, meaning to say the initial clot was a large vessel occlusion. It could be an M1 or it could be a basilar. And after thrombectomy or thrombolysis, when we go in and we do the angiogram, we actually see that the clot has either migrated distally post-intervention or, it's migrated distally. And what we do see is actually that there's also an increasing trend. We are doing more of these distal and medium vessel occlusions along the years. These are, in my mind, due to a few things. Firstly is operator confidence, where we're more confident dealing with vasculature that's further and deeper into the brain vasculature. But another big reason is also because the devices have gotten better and the imaging has gotten better. We have now more specialized devices that allow us to go much further, and it's also much safer for treating distal and medium vessel occlusions. So this is just a very quick summary of sort of 12-year blocks of our data. And what we've seen is that year on year, there's increase, and almost 20 to 30% increase. And I think this year, we are projected to do, we have already exceeded what we have done in the preceding 12 months, and we're projected to do about 70 over distal medium vessel occlusions alone. Yeah. In terms of devices, we are predominantly aspiration. We will try aspiration first before stent retrievers, and it's in a ratio of about 2 to 1. We do sometimes also use stent retrievers as a primary technique if we feel that it needs to be done, but it's less common. And the reason being, when we actually analyze our data, we've had no procedure complications from aspiration first technique for distal medium vessel occlusions, but we've had about 4 procedure complications from using stent retrievers. And what I mean by procedure complications are that the complications are dissections, perforations. These are things that you have to be aware of, because when you're putting a stent retriever in a distal vessel, even if you're not perforating a vessel, just a simple act of pulling it, traction on these very fine and small vessels that are distal actually may cause vessels to either avulse or adjacent vessels to tear, or that vessel may dissect. Yeah. So when we sort of approach distal and medium vessel occlusions, we sort of use this algorithm for us in our center. We look at whether there's either a residual or new clot in the distal medium vessel vasculature, and then you have to decide whether it's an eloquent vessel. Is it supplying the territory of the brain that will result in significant disability of the patient if you're going to leave the vessel occluded, right? If that answer is yes, it's an eloquent vessel, then the next question you need to ask yourself is, can you access that vessel for mechanical thrombectomy? Right? If it's a yes, then you'll go on to perform thrombectomy, right? And I think this yes has been expanding in indication over the years, as I explained, because of patient, of course, of operator confidence and also better techniques and devices, right? If you're unable to access the vessel for mechanical thrombectomy, then the last option is actually just to put a microcatheter as far as possible, as close as possible to the occlusion, and just infuse IA thrombolytics as well. That works in the literature. In my own hands, I found that it's a little bit patchy. I would still prefer to, if I can reach it, try and retrieve the clot with a device. But if you have no choice, then you can try IA thrombolysis. Yeah. So I'm just going to show you a few cases of that have been culminated from our center, also to highlight some of the tips and tricks and techniques that we have found useful for us over the years. This is our angio suite. This is the Siemens Icono. So there are a few techniques that you can employ for treating distal medium vessel occlusions, right? You've got direct aspirations, and we have now catheters that are not only small, but they're also very highly trackable. The ones that we have available at our center is the RAID 43 from Penumbra, and also the 3MAX from Penumbra. I think Prof. Baxter actually showcased the Vector, which is 46 from Stryker. We don't have that available in our center, but it's another option. In terms of stent retrievers, you've got the preset light from Candice and the Catch Mini from Bolt. Both go through a 017 microcatheter, and they are very useful for navigating into distal vessels. In our experience, navigating into very distal MC and ACA vessels sometimes may be tricky with a 021 microcatheter, which is the standard size that we use to deploy stent retrievers. And sometimes you have to just downsize to an even smaller microcatheter, an 017, and these are the sort of stent retrievers that will go through a 017 microcatheter. And again, as I mentioned, if you don't have, you're lost in options, you have no other options, then there's always IA thrombolysis, either altiplase or urokinase, whatever is available in your center. Right. So the first case is a 44-year-old gentleman. Right. He was last seen well at about 3:50 p.m. Presents to our hospital with a high NIHSS score of 25 and a left hemispheric syndrome. We did a CT angiogram for him in the emergency department, and this is what we saw, sort of a left mid M2 occlusion. Okay. So this was the setup that we employed. We did with a long sheath Neuromax, primarily with a rate 43 aspiration catheter, and we tracked it over a track 21 microcatheter. And then the wire that we used was a Synchro 014 wire. Yeah. So the rate 43 in itself is useful because it comes in two sizes. There's a very long version, which is 160 centimeter, and there's a shorter one, which is a 138 centimeter. We have found that for the rate 43, if you need to track it quite far into the distal vasculature, one of the techniques that we have employed, and I'll show in this case, so this is the angiogram. Just play it again. So you can see that there's a cutoff, the M2. There it is. Okay. Yep. So we use the sort of microcatheter as a railroad to guide the rate 43 to the occlusion. Right? And this is useful because sometimes when you're going around tortuous vessels, the sort of step off when you're just using a wire and the rate 43 alone, there's a bit of a gap, and that gets caught on the ostium of some of these branches. It may be difficult to get the rate 43 direct to the clot face, but when you put in a microcatheter, you reduce that step off, and that allows you to actually deliver the rate 43 direct to the clot face. And you can only do that if your small aspiration catheter is actually relatively short, which the rate 43 is. You can get a 138 centimeter version. Because if you're using the 160 centimeter version, in my mind, there are very few microcatheters that are available, certainly none in my center, that will allow you to sort of have the microcatheter stick out long enough from the rate 43 to allow you to employ this technique. So once we were there at the clot face, it was direct aspiration, and then from occluded to recanalize. So it's fairly straightforward. Day 5, this patient actually was still globally aphasic, but his power in his right upper and lower limbs had come back to completely normal. And on the MR, he's aphasic because his temporal lobe is still infarcted, but the good thing is that he's regained power of his right upper and lower limb. Okay, second case is a 57-year-old female, last seen well at about 10:15 in the morning. Again, comes to an A&E department with right hemispheric syndrome, and NIHSS is moderate to high at 15. On the CTA, there is both a right M1 and a right A3 occlusion, so sort of like a tandem occlusion, but intracranially. So this is the CT angiogram. You can see on the image on your left, there's a cutoff at the right M1 vessel. But again, what we sometimes also fairly commonly miss, even in our center, is occlusions in the sort of distal ACA territory. And this one, you have one that's quite far deep into the A3 territory. So this was the setup that we employed. BMX 96 from Penumbra, long sheath. It's an 8 French long sheath. And we went in to tackle the M1 first, because it's a more eloquent vessel, supplies a larger territory. And the aspiration catheter that we use is the ENDOVAC from, I can't remember which company, Serenovus. Yep. And the microcatheter we used was the Phenom 21 and the EMBO-TRAP from Serenovus. For the A3, again, we used the rate 43 aspiration catheter from Penumbra. And we used actually a dual wire technique, which I will show, which is actually very useful for also tracking the rate 43. So in this image, you see the occlusions at both sides. The M1 is fairly straightforward and standard. Just employed a stent retriever and brought an aspiration catheter to the clot face, so a combination technique. And this was recanalized easily. But what we have here is to show you this technique where if you're getting caught, and this rate 43 was actually getting caught around a bend at the A2. What we did was we put in a hybrid 008J wire, which is very safe. It's a very, very safe wire to bring in very deep into the vasculature. But because it's very soft and it's very small, it doesn't provide enough support. But what you can do is actually put a synchro inside as well into the rate 43 and allow it to have a bit more support, straighten the vessel, and this allows it to actually track. So I'm just going to play it again if you missed it. Yeah. So the synchro being a little bit bigger, we try not to bring it deep into the vasculature. But once you have 2 wires, you can actually easily track the rate 43, and you see that it will glide up once you have enough support. The contracting, yep, there you go. Yep. Yep. So once we're there, we actually advance the rate 43 into where the clot is, and then again, once past aspiration, we recanalize the A3 vessel. Yep. Yep. So on day 1 post-EVT, again, he recovered most of his motor function in his left upper and lower limb, and he had resolution of his neglect. Right? And this is also CT done a few days later. There's some mild hypodensity in the right frontal lobe, but otherwise looks pretty good. Third case, we have a 59-year-old gentleman, last seen well at 3:15, also presents with a moderate NIHSS 16 right hemispheric syndrome. On the CTA, there was actually a carotid bifurcation. Intracranially, it was normal. All the vessels were not occluded. Right? So what we did, we sort of did a acute stenting of the carotid artery. Right? There was a balloon. That's the filter device distally. And then we stented across, kept the vessel open. But when we did the angiogram, we realized that there's probably a small clot that had escaped the filter device and lodged itself in the A3 vessel. Right. Considering the patient was actually quite high functioning before, I think he was managing a large finance company, we decided to make an attempt at treating this small vessel. So again, we employed this technique where we used the microcatheter to reduce the offset. You can see that the rate 43, as it goes around some bends, it may struggle a little bit. But what you can do is just use the microcatheter, bring it just past the clot, and then using the microcatheter as a railroad to railroad the rate 43 all the way to the clot face. That allows you to reduce the step off, and that tends to work very well. So once we're there, aspirate, again, you get recanalization of the A3 vessel. And day 3 post-EVT, his power in his left upper and lower limb had gone back completely normal. There's no neglect, and his speech was normal. And on the MR, this is all you see, a very small spot of infarction in the right frontal lobe. Right? So I've still shown you 3 cases of aspiration. I have to throw in a stent retriever case just to make it complete. This is an age 3-year-old lady, last seen well at 7. She came in with sort of a mild moderate stroke, NIHS of 11. On the CTA, there was a right M2 occlusion, right, somewhere around here. What I didn't realize at that time was it was actually not really M2 that is sort of second order branch, because and this was a setup, when I did the sort of angiogram, it was actually a vessel that was already a third order M2 that was occluded. But since she was symptomatic, and some of the vessels did look as if it would be eloquent, there you go, there's an occlusion there, I decided to give it a go and try and recanalize it. So my first approach was to try the rate 43 again, right? Again, using the hybrid 008J from board, very safe wire. I love it. It's very good for taking these kind of crazy turns. You can go blind. I've never dissected anything with this wire. But the problem with the wire is it's sometimes a bit too soft. And when you're trying to sort of make an acute turn with the rate 43, you may struggle. And in this case, I couldn't do that. But what I did manage to do was switch down to a system, put a small microcatheter across, and then deliver a preset light stent retriever across the occlusion. And this is the delivery of the preset light. And the preset light is actually a very soft stent retriever. It allows you to sort of deploy it very deep into small vessels and then pull it with less traction. I wouldn't say there's no traction, because if you look at the sort of image of the stent retriever in the vessel, there's already some distortion of the vessel. But when we sort of retrieved it, we recanalized the vessel. There was a bit of distal clot, but that was really deep. It's probably M4 territory. Wasn't going to chase that. Patient did very well. Day 4 post-EVT, she had only residual mild dysarthria, but power in left and upper lower limb were normal. She had no neglect. She was discharged less than a week after her EVT. And this was the MRI that was done for her a few days later, just a few spots of DWI infarction. Yep, so that's the end of my cases. Happy to take any questions, and this is the team at SGH, my colleagues. Yep.
Thank you, Dr. David. Is there any question?